Thank you, Anna. Thank you.
Yeah, absolutely.
I think we should end this session here. Again, Dan, thank you very much, Ala, for an excellent talk. And thank you for being able to join us there. Thank you.
Thank you so much for the invitation. I appreciate it. Bye-bye.
Very good. Very good. Now, we're moving on, and that leads nicely to our next speaker, a dear friend, a colleague, Professor Billy Bourke is a consultant pediatric gastroenterologist at Children's Health Ireland, Crumlin in Dublin, Ireland. Billy is a very experienced gastroenterologist, and he's always the go-to person if we're stuck. We share a lot of patients with Billy, and I'm sure today he's going to shed some light on the CF liver disease advances and challenges. Billy?
Thanks, thanks, Basil, for that great whittle. I just get my sharing my sharing thing organized here. I was not doing very well with Mohammed when we practiced this, but I think I have it sorted. 2 seconds. And Basil, tell me if you can see this okay. Yeah? Are we good?
Yes, we are okay.
I beg your pardon, I'm at the end of it for some reason. We just end it. 2 seconds. Good. Okay, thanks again, Basil, for that kind introduction, and thanks to the organizers for the invitation. My interest in CF liver disease started when I came back here from my fellowship in Toronto over 20 years ago, and it was mainly because we had a big collection of unfortunate children with CF liver disease within our group here in CHI Crumlin. So I'm going to talk a little bit about the clinical manifestations of CF liver disease and the practicalities around it, but I'm also going to talk about some of our research over the last 20 years in this area, particularly with regard to outcomes. I'm going to leave plenty of time for questions at the end, so I'm not going to bamboozle you with too much data, because I know most of the people on the call or on the conference are actually probably respirologists rather than liver specialists. And there are lots of different manifestations of cystic fibrosis liver disease, and here are a list, but in reality, the heavy lifting is around the cirrhosis and portal hypertension. And from a patient morbidity perspective, this is the group that we need to look at. The prevalence of CF liver disease really depends on what definition is used. And in fact, if you confine it to a biochemical or indeed imaging definition, you will find that over 30% and even more in some studies of your patients will fit the diagnosis of CF liver disease. But most groups, including ours, use this terminology specifically for those who have portal hypertension due to fibrosis and cirrhosis. And this is reproducibly under 10% in CF populations. And our own Irish population, it's 7%, which is consistent with other groups. From a hepatologist perspective, this is a really unusual condition. It's a really unusual form of liver disease. It's very slowly progressive, and it's predominantly portal hypertension. In other words, the manifestations of the liver disease are predominantly portal hypertensive instead of hepatic synthetic failure or cholestasis. Splenomegaly and hypersplenism are out of proportion to the other manifestations. We usually find the disease, if we're looking carefully, around the end of the first decade, but it can easily be missed. And it's likely that many of our children are actually starting their disease long before it becomes clinically obvious, or even perhaps biochemically obvious. It's odd that there doesn't seem to be new disease after later adolescence. Now, I acknowledge there's a recent paper that suggests there's an adult form of CF liver disease, but I think we need to do further research to determine exactly what that is, because in general, this disease, if it is not there by the onset of puberty and mid-teenage years, is probably not going to occur. And this other really odd thing that it seems to decelerate in its progression after 18 years of age. So my patients usually don't get much worse after they've gone through puberty. And if they do progress, it's quite slowly. We really do not understand how this disease occurs. The classic description of the explanation for the pathophysiology relates to the expression of CFTR and cholangiocytes. and the changes in pH and bile flow that occur. But there are lots of reasons to believe that this is an inadequate explanation. Some really exciting new data coming out on the possibility that it's the immune modulator function of CFTR on the cholangiocytes and the subsequent influence of the microbiota and inflammation, which tips the balance and results in a select group of patients with CF developing this complication. But again, this is early days. We do know that males, in all studies, males outnumber females, usually in a 60 to 40% ratio. And we, of course, know that there are other genetic influence in them. Most famous, obviously, is this thing with the alpha-1 antitrypsin gene increasing the risk for CF liver disease significantly. But you have to remember that the heterozygous state for alpha-1 antitrypsin in CF in general is only 2.2%. So the actual contribution of alpha-1 antitrypsin to CF liver disease is actually quite small. So what about treatment, which is the nubbin of the problem for us on a day-to-day basis? And this is both frustrating and somewhat controversial. I'm going to talk briefly about the major points here. Ursa Falk, general nutrition, which in fairness, Dr. Shai Khalil talked about extensively in the previous talk. Management of the portal hypertension problems and liver transplantation. So Urso is a very controversial medication. It is safe as far as we can tell, and many authors and experts in the area suggest that it be used at diagnosis. But the problem is that most patients with abnormal liver enzymes or ultrasounds will not, in fact, progress to fibrosis and cirrhosis. And so who do we put on this medication? Everybody? It's very difficult to predict who's going to progress, and there's no clinically proven benefit of Urso, even though it does reduce the liver enzymes and the bilirubin in some patients and increases bile flow. And there are a couple, at least two, Kaplan reviews which do not support the use of the medication. And we have to remember that in at least one adult study in another form of cholangiopathy, that's primary sclerosing cholangitis, the outcomes were worse in those who took Urso. So for what it's worth, in our unit, we do not use it. We were interested in the impact of nutrition in CF liver disease when I started to work in this area first. And this was because so many of our patients were so poorly nourished clinically. And we thought there was an association and perhaps a risk for poor nutrition for the development of CF liver disease. And the data from existing studies were not really supportive, or at least ambivalent or ambiguous about whether there was an association or not with the presence of liver disease. And so briefly, we undertook a study where we took all our known CF liver disease patients in the clinic and we age and gender matched them carefully with a non-liver disease control, and we looked at their nutritional outcomes. And you can see from this graphic that there is a statistically significant difference between CF liver disease and controls with regard to both weight and height. We published this in Journal of Pediatrics some time ago. We also found that body composition was different. So when we did anthropometry, we could see differences in particular in muscle mass and mid-arm circumference in the patients versus controls. I have to say this is something we see in other forms of liver disease as well. So again, cause and effect couldn't really be explicated from these data, but nevertheless, it is quite interesting. And this wasn't actually published because it was a subgroup of patients, but I think it's one of the most interesting pieces or tantalizing pieces of work that we did around this. And what we had was a subgroup of patients where we had good centile data, as you do in CF, because people are always looking at their growth. And we retrospectively plotted back the controls versus the cases. And you can see that this one is for weight, but in fact, the height was the same. And you could see there was a change between the controls and the cases that started way before the diagnosis of liver disease. Again, making us speculate that maybe the nutrition was causative rather than a result of the liver disease. So with regard to nutrition, Alice kindly covered all of that area, so I don't need to do it again. I concur with all that she says. I would only add, I think that oral calorie supplements, which we still use all the time, I'm completely atheistic on. I think children, if we give them oral calorie supplements voluntarily, as opposed to via gastrostomy sites, they simply replace normal food with the calorie supplements. And I think there are good data published by Smith and Walters in a Cochrane review some years ago around that. And then I was going to mention, just as she did, this is a problem that we're beginning to see with the patients who have been treated with modulator therapy, developing obesity and subsequent non-alcoholic fatty liver disease, we call it, which is basically fatty liver. Obviously, if you have an underlying tendency towards liver disease, such as cystic fibrosis, and you put in a fatty liver that's unrelated on top of that, we could be in for some trouble in our populations as time goes by. And so we need to watch this carefully. And so the core work for us is managing the complications of portal hypertension, which of course are ascites, varices, and massive spleens. So in the treatment of varices, beta blockers are preferred for primary prophylaxis. In other words, to give to patients who have large varices before their first bleed. And this treatment is used worldwide in adults because there are very good data to support it. But our experience of using beta blockers in children, particularly with CF liver disease, is very poor. They're very poorly tolerated. And there is at least a theoretical concern, because to adequately beta block somebody to reduce their risk of bleeding, you need to give them a bradycardia, a significant bradycardia. And the worry, of course, in children is that they need to increase their heart rate in response to hypovolemia if they did have a bleed, more so than in adults. And that could put them at higher risk, although nobody's ever shown that for sure. We don't find it terribly useful and tend to reserve it for patients with, say, gastric varices where we don't have easy option therapeutically. So we go to primary prophylaxis using band ligation, and there are good data from other studies that give us circumstantial support, if not direct support, as this being the appropriate way of doing it. So in other words, if we see, when we screen for large varices with red signs, which means they're at high risk for bleeding, and we find them, then we go ahead and band them even though they haven't had a bleed. So we use it for primary prophylaxis before the first bleed, and indeed secondary prophylaxis if they have had a bleed, and we band them repeatedly until we extinguish the varices. And it's very effective and it's very straightforward from my point of view. There are, of course, patients who run into bigger problems with their intractable varices and intractable ascites, massive splenomegaly, a controversial area, very little data on it, but there's case reports in small series from certain groups using TIPS, which is intrahepatic shunting, or indeed even for large spleens doing partial splenectomies. However, it has to be said that our transplant colleagues do not like us taking the spleen out, so we often really hold tight, even in massive splenomegaly, and leave the spleen in, even when it seems to be causing patient problems. And so to liver transplant. So liver transplantation obviously is necessary when we have hepatic synthetic dysfunction on top of the portal hypertension. So we usually measure that by hypoalbuminemia, coagulopathy, factor deficiency, etc. But it must be remembered, and it's important to note, that hypoalbuminemia and coagulopathy can be multifactorial in CF and may not actually be liver related. So it's important to consider things like vitamin K deficiency, for example, or indeed the hypoalbuminemia we see when patients come in sick with intercurrent pulmonary infections. And also low-level hepatic synthetic dysfunction is not unusual and may be very, very slowly progressive over time in established CF liver disease. I would also point out that the onset of cholestasis in CF liver disease portends a very bad prognosis. It's not common, but it's something to watch out for. Liver transplant outcome. I'm sorry, this slide is a little bit busy. It didn't translate very well into the slide format. But if you look here, the outcome from the UNOS, that's a US audit agency for transplantation for pediatrics in particular, the 1 in 5 year survival in their 28 report was 86 and 78% for children undergoing liver transplant for CF, which is actually quite close to the overall cohort. And the updated data, although there are more to come, they're not out yet, but in 2011 it's higher again. And we're seeing this across all liver transplant, that the survival is improving. There are some single center reports of transplantation survival in CF liver transplantation up in the 90% region now. So it's a good option for patients. And this is a simple algorithm for how we would approach it. It's not complicated, even though it might look initially. And clearly, if you get into a patient who's got significant CF liver disease, but has good synthetic function, and you can control their varices or ascites, then clearly you continue on that role. And that's most patients. And if there are problems around varices, you might consider shunt surgery, although again, complicated and complex and a lack of agreement on it. And on the other hand, liver transplantation should be considered in those patients who are really difficult to control. And there's this notional 40, well, not notional, but I think people use it practically, a 40% FEV1 cutoff for going to liver transplant or considering lung liver transplant, which is obviously a whole different game in terms of the patient's outcomes. So you will remember we looked at the nutrition of our patients in a case-controlled group back in around 2000 or just before 2000. So we decided to follow those groups out and see what happened to them, because our sense was that our patients were not doing well overall, those who had CF liver disease. And you can see at 7 years, we're beginning to see difference between those who had liver disease versus those who did not have liver disease in numbers of deaths. But at 10 years, this is statistically significant. It's highly statistically significant. 40% of our CF liver disease cohort were dead. And remember, this was a tightly age and gender matched control group. And you can see that much fewer of those who did not have liver disease, had no evidence of liver disease, actually had mortality. So a big concern. I'm going to come to that in a prospective study in a minute. This is what the Kaplan-Meier curve looks like, and it's not very pretty at all, obviously. So we need to watch these patients fairly carefully. And this slide is just to show you that these patients are not just dying of liver problems, but they're actually dying more of pulmonary failure as well. In other words, the CF liver disease seems to be a marker of worse phenotype. And I think a lot of hepatologists, pediatric hepatologists around the world would agree with that concept, although there are data from Chapel Hill in particular that suggests that the lung disease is no worse than CF liver disease. And most other studies haven't shown that. So one other question that we wanted to address in our study is in our long-term follow-up studies was what happens to patients who have non-specific CF liver disease. In other words, those who don't have portal hypertension but have abnormal imaging or abnormal liver enzymes or both. What happens over time? And this is a question that we come up against all the time. And I think many of the respirologists in the group will find this as well. So we decided to look at this in a prospective way. And one of the advantages of living in a small country is that it's quite tractable with regard to whole populations, whole population cohorts. And with few CF centers and all centralized care for liver disease in one place, it made Ireland attractive for it. So we did a nutritional, clinical, biochemical, radiological assessments of all patients with CF in the country in 2007. Followed them in 2012 and 2016. We classified liver disease according to the North American classification into, and it's a simple classification, no liver disease, non-specific liver disease, those with enzyme and imaging abnormalities, and those with cirrhosis. And these are just some brief data from these studies. We had 521 children enrolled in 2007. And of those, 22.8 had non-specific CF liver diseases versus those who had no evidence of liver disease, which was 70%. And 4 years later, there was a significant difference in the mortality between those with non-specific CF liver disease versus those with no liver disease, which is a concern. And the other interesting thing, and this comes back to the issue of what happens to non-specific CF liver disease. So we wanted to follow them forward and reclassify them, and we did so in 2012. And about 11% had progressed to cirrhosis and fibrosis and portal hypertension. A third were unchanged, and a third had no evidence of liver disease, or 40%, I should say. So what happens to these children, who changes and why. So we're not really sure yet, and we're analyzing data from 2017 at the moment to see if we can come up with factors. But it isn't age, because those who were under 10 or over 10 progressed in the same way. We did notice that the group who had both significant liver and biochemical abnormalities were more likely to progress, and this may be a marker, although we wait to confirm this. And here's the very beginning of our 10-year follow-up data. This is a huge concern. You can see at 10 years, 50% or more of all of our CF liver disease patients diagnosed in 2007 are dead. And this is a phenomenal figure. Now, it correlates with our retrospective data on the case control study, but it's even more stark. And you can see there's an increase in the mortality rate for non-specific CF liver disease at about twice the background rate for those with no liver disease. So again, an interim mortality rate. And again, what happens to those with non-specific CF liver disease in terms of change of categorization? And you can see that data are not too different from the original 4 years, with 15% progressing to CF liver disease, 50% staying the same, and about a third not having any evidence of liver disease on follow-up. And we need to figure out why, which patients are those that are going to progress versus not progress over time, and we don't yet have those data. So I'm going to wrap up with a couple of quick slides about conclusions. So the conclusion from our data is that very high 10-year mortality in patients with cystic fibrosis who have CF liver disease. And I think if you look at other studies coming from other centers, there's a similar kind of result, although it may not be quite as stark as ours. And ours is a prospective national patient cohort, so quite strong in that sense. The other thing is that there's an intermediate mortality for patients with non-specific CF liver disease between those of no liver disease and those with CF liver disease. And those patients who come to you with minor abnormalities such as transaminase abnormalities, GGT elevation, or abnormalities on liver imaging, what's going to happen to them? Because they will want to know and you will want to know. Well, it looks like only a minority, 10 to 15% over 10 years, will progress to cirrhosis and fibrosis. But we do see an interim mortality, intermediate between CF liver disease and no liver disease in this group, and that needs to be kept in mind. And children with both biochemical and imaging abnormalities may be the group at highest risk of progression, and hopefully we'll have more data on those risk factors in the next short while. And in summary then, I would say that the risk factors and implications for CF liver disease are evolving with time. There's a pressing need for effective therapy for target groups, and there's a pressing need for us to identify who are the patients at risk for developing CF liver disease. But in the meantime, we should see CF liver disease as a marker of significantly poor prognosis in this condition. And this is going to become more and more important with the development of modulators and changes in the natural history of the respiratory function. And it's not at all clear at this stage whether these new modulators are going to help or not CF liver disease. There are some data from in vitro models that would suggest it may not at all be that straightforward. We need to target this group for intensive treatment. My colleagues would say all their CF patients get intensive treatment, but we need to acknowledge that this is a particularly vulnerable group. And we're very much advocates for early consideration for those, even if they're stable, who have advanced portal hypertension for liver transplantation, because they do so well. I'd like to finish by thanking my colleagues. Marion Rowland was the brains and brawn behind all of this, particularly the epidemiological work, and Lucy did her PhD and Jennifer did her MSc on the back of the data, and all my colleagues around the country, including Basil and his colleagues in Tala and others, and of course our funders, which is the Health Research Board in Ireland. Thank you.
Thanks very much, Billy, for an excellent talk and shedding the light on the liver, which is obviously a very important organ for us in pulmonology. A question, Billy, do we need to do a biopsy to diagnose cirrhosis in CFLD or diagnose CFLD in child?
So a nice, easy question to start with. So the problem, so we don't, unless there's a question of some other disease or to clarify things. And the reason we don't, and most groups don't, is that it's such a patchy disease. A liver biopsy will often give you a false sense of what's going on. So it's not a terribly useful clinical thing to do. Now, there are groups around the world who disagree with this, one in particular in Australia, but I remain to be convinced, to be honest with you. And I think most of my colleagues would also feel that way. So we don't do it unless there's another question to ask. Like, for instance, could there be autoimmune hepatitis here, which rises from time to time?
Sure. And, you know, I share with you, and obviously the view that our other colleagues would say that once they receive the young person or transition to their care, if they have liver disease, then they continue. If not, they don't see de novo, if you see what I mean, arising in the adult population. Yeah. What's your view on this sort of what people call obliterative portal venopathy without cirrhosis? Is that something?
Yeah.
Is more of an adult type of thing, or?
No, I totally agree. I think it's fascinating. In fact, I think it's probably the next area we're going to try and see if we can explore. We've managed to recruit top world-class hepatologist from King's College Hospital, Emer Fitzpatrick, and she's really interested in this. And I think we're going to start looking at it. We think it's probably the reason that the patients get such profound portal hypertension, hypersplenism, that there's actually a vasculopathy, a prehepatic vasculopathy as part of it. And there are some really tantalizing data in small series to support that. So yeah, really interesting.
And could this be modulator responsive, reversible?
So the problem with that is that unless we understand the mechanism, it's going to be difficult to do that. And for instance, we have other patients who are non-CF who have these. They're very rare, but we do have them who have these conditions, non-cirrhotic portal hypertension, it's sometimes referred to, and there is no treatment for them. They go to transplant actually once they get bad enough.
Very good. A question here. The conundrum of following up non-specific liver disease leaves many of us scratching our heads. Are there any liver ultrasound scoring systems which might be helpful in isolating the at-risk groups?
So there are loads and loads of publications looking for trying to determine what are the factors that might identify patients who are going to progress. But I can tell you that it's not going to lie with ultrasound, and our feeling is that it's not going to be with transient elastography either, which is having a moment. It's very popular at the moment. I won't get into why, but our studies would suggest it's not going to help. And unfortunately, ultrasounds are so subjective that I think honest radiologists will tell you that they can't tell who's going to progress. So unfortunately, as things stand, we can't tell based on imaging, and we can't really tell based on enzymes either who's going to progress and who is not. And we have the data in terms of what percentage go in which direction. And so hopefully, because we have multiple factors to analyze, and so hopefully we'll come up with some sort of answers for this, but at the moment we don't know.
Another question, what's your take on FibroScan or FibroScan elastography?
Yeah, so that's the transient elastography. Very, very popular, lots of publications in CF and lots of publications in other diseases. It was really developed for hepatitis C and fatty liver to avoid having to do biopsies in adults. I have to tell you that we wrote a grant on the back of doing this to be able to determine who's going to progress and watch them and monitor them and all the rest of it. And we actually had to publish recently that we found it unhelpful because we could not find it to be reproducible enough in normal populations, never mind in CF. So there's an issue there, and it's been ignored in a lot of the background data on transient elastography, that this is not a very reproducible day-to-day technique. So it'll tell you if somebody's got bad cirrhosis, bad liver disease, or no liver disease, but the ability to discriminate within that, within the group who are going to progress slowly over time, we think it's not going to be there. That's our particular bias from our research.
Very good. I've got 1 minute left, and I know your view on this, and you touched on it, but I have to say the question here: what do you think about ORSFOG?
So we talked about that briefly on the talk, and I think you gather from me that I'm an agnostic. I'm an atheist actually on this one. I don't believe in it. I really don't believe in it. It doesn't make sense. I work with a super colleague who did some basic science research in animal models on it years ago, and she said it actually hasn't got any rationale for use. It certainly won't work if the patient has developed liver disease and cirrhosis, and nobody thinks it will do that. The only other approach is to put everybody on it. But I don't think we can do that. I don't think there's enough data for it. The data do not support its benefit as things stand. So I think we need new treatments and new looks to put patients on to identify drugs first. And they're really fascinating. Sorry, Basil, going on. But
all right, now go ahead.
the really fascinating thing is going to be what are the modulators? What is triple therapy going to do? And we don't know yet. We really don't know. I know people talked about the toxicity, but in fact, that seems to be extraordinarily rare, as Alice said. We haven't seen any serious toxicity. We're using a lot of modulators in Ireland.
And hopefully, as our previous speaker, Jane Davis, was on the call earlier, and she spoke about the promise in the US and our own recovery in Ireland and the UK, hopefully that will shed some light into this problem.
Exactly.
Well,
we're involved in that, yeah.
Absolutely. Billy, thank you.